My name is Bob McCarthy, president of Vitacyte, and I am very pleased to have Bashoo Naziruddin, or Nazir, give us a seminar on his work on the challenges facing isolation of high-quality islets for total pancreatectomy with islet autotransplantation. Those in the U.S. know that this is a very hot topic, simply because it's one of the few, it's the only islet transplantation procedure that's and it can get third-party insurance payers to pay for the procedure. So this whole webinar started actually was because I saw Bala pointed out the paper that Bashoo or Nazir just wrote on the laminin alpha-5 and how it correlated with poor islet yields. And I thought that was a fascinating observation. I wrote a commentary on this, indicating that this is what I have always thought, is that we should be using multiple protease enzymes, because the collagenase, as far as I'm concerned, the collagenase issue is solved. You should be able to get really good, well-characterized collagenase. So getting to the issue at hand, Nazir has had extensive training. I found out in preparing for this webinar. Actually, he was trained at Washington University with Paul Lacey's group with Barb Olak. And at the time, and he remembers it, with Mary Jo Wright, who was part of the Liberase team, would go down and work with the WashU group about trying to see if we can get increased yields using Liberase. So that was a long time ago, and everyone has a history in training somehow, somewhere, because you don't learn this by reading a cookbook. So anyways, it was great that he was able to do that. When we chatted as well, he brought up the issue and we've thought about it. And I think there's still an absence of dialogue, which is why we started these webinars, to talk about technical issues around human islet isolation. So in that vein, I'll send out next week a poll or a survey to people who are registered for this webinar to see if you're interested in attending an online workshop for TPIAT. I think there's a need for this. Of course, to run one of these workshops, there'll have to be a fee, but I'm just curious to get your feedback. So if you are interested, please reply to the SurveyMonkey survey, and we'll go forward. You can always contact Nazir about specific questions. He has agreed to share his slides, which will be on the website. So without further ado, Nazir, thank you for agreeing to give this webinar, and we look forward to your presentation.
Thank you, Bob, for this wonderful introduction. And thank you, I think, to Vitacyte for giving me this opportunity to share my experience in the field of auto islet transplantation, as a matter of fact, in the pancreatic islet transplant itself. So today, what I thought I'll present to you is this my experience, where we are going to talk about three things. The objective of this talk will be to learn about the technical aspects of total pancreatectomy with islet autotransplantation, more on the transplant or isolation of the islet side rather than the surgery side. And also, I would present the Baylor's result in the last 20 years on in the clinical outcomes, the post-transplant glycemic control, or some of the data that we have on islet isolation. And the third part, the last part of the objective will be to understand some of the biomarkers that we have presented that will help in the prediction of islet yield and post-transplant glycemic control. So the presentation will be in three parts, just as I mentioned. The first part will be on the technical aspect. The second part will be the Baylor results. So let me get into the first part, where we talk about pancreatic islet transplantation. This slide is more for the newcomers who don't know much about the field, that in the human abdomen you have a pancreas that plays primarily two major roles. One is the exocrine function, where it secretes enzymes that are helpful for the digestion of the food. And the second part is the endocrine function, where the pancreatic islets secrete the two major hormones like glucagon and insulin that really helps in the regulation of blood glucose or keeping the normoglycemic condition. So in the diseases that affect the pancreas, there are at least two major ones for which pancreatic islet transplantation is used. One is the type 1 diabetes, which is an autoimmune disorder where the patients are detected with diabetes after all the insulin-producing beta cells are destroyed due to autoimmune response. And the second one that, like Bob mentioned, is the chronic pancreatitis, where due to the failure of any other procedure to reverse the disease of chronic pancreatitis, the surgeon decided to do the total pancreatectomy. So from this inflamed pancreas, we isolate islets and then infuse into the patient. So the advantages of islet transplantation is that it is still a minimally invasive procedure. And then importantly, when compared to the artificial things like insulin pump and the closed loop system, islet transplantation presents an opportunity of physiological restoration of normoglycemia. And there are thousands of patients who have gone through this procedure, and the data shows that the islet function can be maintained for a prolonged period of time. Even there is a report from Edmonton of more than 20 years of insulin independence after islet transplantation. And several studies have also shown that for patients who receive islet transplant, the quality of life is significantly improved without the procedure. And it also, this procedure, islet transplantation, prevents from long-term complications of diabetes. So when we talk about islet transplantation, again, this slide is for the newcomers. There are two different types. The one that is more, I think, more prominent is the allogenic islet transplantation, where the pancreas is procured from a deceased donor or an organ donor. And then the pancreas is brought to a cGMP lab where we islets are isolated. And then following the isolation, the islets are then infused into the portal vein of a recipient. And this is the widely practiced procedure. But the second one, which I'm going to talk today, is the total pancreatectomy with islet autotransplantation. In this procedure, the pancreas, which either has already got a long-term chronic pancreatitis or has already undergone previous surgeries to try to cure the symptoms, this pancreas is removed by the surgeon and then given to the islet team. So the pancreas is brought to the islet lab where the islets are isolated, and then it infused back into the patient through the portal vein by the same day. In most centers, it's done in the same day. In some cases, I've heard that even islets can be injected the following day with culture. But this procedure typically starts like early morning where the surgery is started, and then it takes about 4 to 6 hours or sometimes even 7, 8 hours for the pancreas to come out, depending on the inflammation condition or the patient condition. Once the pancreas is out, the isolation takes 6 to 8 hours for it to complete, and then the infusion is done the same day. So when you look at the differences, what is the major difference between allogenic islet transplant and autologous? As I just mentioned, allogenic is mostly for the type 1 diabetes, and whereas autologous is for refractory chronic pancreatitis. And in the case of allogenic, immunosuppression is required to maintain islet function, which is not necessarily a good thing because some of the immunosuppression medication that's being used, like tacrolimus, is also beta cell toxic. So it slowly kills the pancreatic islet function or the islet cell function. Whereas in the autologous case, that immune response is not there because it's a self cell. So, so we don't have to worry about that. And in the case of allogenic transplant, the recurrence again of autoimmunity is also a concern, whereas that is not a concern in pancreatic autologous islet transplantation. And more importantly, just like Bob mentioned, autologous islet transplant is already recognized by the insurance industry in the United States, and it's reimbursed. So that's really important because in many centers which perform islet transplantation, performing allogenic transplantation under a investigational new drug application or IND is extremely hard, is very expensive. So that's why many centers have stopped performing this. And now the FDA has cleared one company in Chicago to do this allogenic islet transplantation under a biological license application. So until many centers get this BLA or get some way of performing more cases where they can be reimbursed for the costs associated with allogenic, the number of transplants in allogenic is really low. Whereas the autologous, on the other hand, has seen a steady growth. And as you can see in this slide, it was by Bernie et al. In 2022. There is a general expectation that the United States perform more islet transplantation, which is not true at all. The Europe has performed more islet transplantation, both autologous and allogenic combined, in like more than 2,600 cases in Europe. And whereas the North America, there are 1,475. In this data, actually, the Canadian team has performed more transplant than the United States. And there are also islet transplant centers in Asia, like China and Japan and Korea. And in Australia, also, there is an active islet transplant program. And United Kingdom also has a significant number of patients in this field. So this is the data from Collaborative Islet Transplant Registry, and it shows that the number of allogenic transplant procedures over the years have grown, and now in the last 10 years or 15 years have kind of slowed down or stabilized, whereas the autologous, the number of cases are increasing. So now the number of autologous have almost reached a similar number. If not, they're going to exceed the allogenic procedures performed. So with regard to the patient selection, see, in the case of allogenic, it's very straightforward. That is mainly meant for type 1 diabetic patients who have lost their islet insulin-producing capacity. Whereas the TPIAT is different case. Actually, it has got a broad spectrum of patients. You know, some patients who have genetic etiology, some patients who have alcohol history, some people have drugs. So the disease etiology is different for TPIAT. So there was an NIDDK workshop in the year 2014 with Dr. Melina Bellin being the head of that workshop. And then this workshop has recommended to follow certain criteria. So in Baylor, where I work, we follow this criteria now. So this is based on, there are at least 1 to 5 criteria listed in which there will be like 2 or more must be seen in this patient for them to be selected. So this selection involves observation of pancreatic images where they see pancreatic calcifications, or there are abnormal ERCP data, and there is also histopathology of confirmed diagnosis of chronic pancreatitis, and then there is also hereditary pancreatitis is also documented, and the pain. Unlike the allogenic islet transplant, which is mainly performed to restore normoglycemia using pancreatic islets, the autologous islet transplant is performed primarily to control pain, and then improve the quality of life associated with it. The purpose of transplanting islets is to keep the endocrine function going, and actually during the post-transplant period, whether this glycemic control can be maintained. So that is the secondary objective. So the other criteria that are important for TPIAT patient selection is the narcotic dependence of these patients, and also whether the other things like celiac blocks have been attempted, and that does not also reverse the pain. So these are the things that are important for the patient selection. So when it comes to surgery, since I am not a surgeon, I'm not going to talk a lot about the details of the surgery, nature of surgery, but all I need to say is that during the surgery, the pancreas along with a part of the duodenum is removed, and then the rest of the intestinal system is reconstructed. Sometimes the pancreas comes with the spleen, or sometimes it could be a spleen sparing procedure. It all depends on the surgeon and the warm ischemia time that is involved or required to perform the different type of surgery. But in most cases, the pancreas is removed along with spleen. And if the pancreas has already undergone previous procedures like Pusto procedure or distal pancreatectomy or a Whipple procedure, then the surgery can be short or long depending on the condition of the pancreas. Now comes the isolation part. As Islet lab director, we come into the this procedure only after the pancreas is removed. And the isolation of islets for autologous islet transplant is performed in a GMP or a CGTP, good tissue practice facility, and it is regulated by the FDA. For example, our facility where we now primarily perform islet isolation for autologous transplant, we already had FDA inspection for the facility. And we basically are supposed to follow in terms of maintaining this facility, 21 C Code of Federal Regulations, like 210, 211, 610. This is all like general codes that are there described or prescribed for maintaining this facility. And then we are more concerned, focused on the 21 CFR 1271, which is like the GTP for cell and tissue. And along with this code specific for the cell and tissue processing, we also should follow the regulations for facilities, controls, record keeping, labeling, reporting, and then we should be prepared for inspections on the QC program. This is just a picture of our facility in Baylor. So the surgery is performed on the right side. There's the Roberts Hospital. And then we take the pancreas and walk to the isolation facility, a CGMP facility, which is like a couple of blocks away. And then once the surgery isolation is performed, then we take it back to the surgery room for infusion. As many of you know, or maybe for the newcomers, the isolating islets from viable, like islets from pancreas, involves 5 major steps. First is the procurement. We need to make sure that the pancreas is procured in a short time possible, and then we try to avoid warm ischemia time. You know, the pancreas should not be kept at high room temperature for a long time because it leads to auto digestion and also poor quality islet yield. And also, there is lots of studies about how to preserve the pancreas once it is coming out of the patient. There are lots of studies that have been reported, but in general, this preservation is not a major issue in autologous because we usually keep the pancreas for less than an hour. We just take it from the patient and take it to the isolation facility. I think this is true for majority of the centers where the pancreas is transported to the islet isolation facility in a short time. In some places, I have heard that the pancreas surgery is performed and the isolation is also performed in the same suite. But that means the preservation of pancreas is not a major issue in this field. Then we go through the isolation of pancreatic islets using the semi-automated method originally described by Dr. Camillo Riccardi. Actually, a lot of progress in isolating islets for TPIAT has come from allogenic islet isolations where a lot of effort has been put in. So we'll just go through the details a little bit. And in the case of allogenic islet transplant, purification of islet is an important procedure to reduce the volume and also keep the pure islets for infusion. In the case of autologous, purification is not necessarily an important step because we would like to infuse as many cells from the pancreas as possible back into the patient because this is autologous and the patient is not going to get more from that out any other source. So in this case, what we do is in majority of the center, they have a formula which is originally described by University of Minnesota. If the patient is like 80 kilogram, and we do the pancreatic digestion, once that at the end of the digestion, if we have a 20 ml of tissue, which is 1/4 of the patient weight, then that volume is sufficient to be infused intraportally. If the volume exceeds, like say we get 50 ml or 60 ml tissue, which is not improbable because in some cases we do get high tissue volume. In that case, we resort to purification. Again, the goal of the purification is to collect as many islets as possible and then reduce the pellet that can go into the intraportal route. And then we take the cells for the infusion into the operating room. Actually, this is the main slide. This slide tells the whole story of islet autotransplant and the challenges that are being faced. As you can see, there are like about 5 pancreases I have shown here. On the right side is the normal pancreas, which is collected, which is procured from a diseased donor. When it comes to a diseased donor pancreas, we always look at selection. For example, what was the patient age, patient's BMI, hospital stay, and all the other conditions. Then we only accept donors which have the possibility of giving us the best islets possible. Whereas in the case of chronic pancreatitis, the islet lab people have no choice. We just are given a pancreas in whatever condition, and then we are supposed to extract islets, particularly high quality islets, so that the patient can benefit out of it. Here is the big challenge, because these pancreases that are given to us from the operating room are actually, put in a simple term, as a mess, because some of the pancreas have already undergone different procedures like Pusto procedure, Whipple procedure, distal pancreatectomy. And if you look at the pancreas that I'm trying to show here in the middle of the slide, it is a completely fibrotic pancreas. And the other day I was describing it to Bob. See, in one of our very first cases, even some cases later on, when we try to bring this pancreas and then after try to do the enzyme infusion and try to cut the pancreas into pieces, the scalpel broke. That means the condition of the pancreas was like a rock. In fact, some of the surgeons in Baylor make fun of us, saying that you guys are trying to get some water out of the rock, something like that. So this is an extremely difficult challenge, and that's what we are trying to discuss today, how we can improve the islet quality and yield. And in addition to the fibrotic or pre-surgery to the pancreas, here is another huge complication. Quite a few of the cases, the pancreas has calcification. And you can see here on the left side is the pancreas that we actually use for a transplantation, for autotransplantation. On the right side is the pancreas, the calcification, that are the calcium stones that we got from this pancreas. There is no scale here, but I can tell you on the left side, the size of the stone is around 1 to 2 centimeters in diameter. So such big stones, and these stones clearly reflect the pain that the patient was experiencing, because we always collect the data on the patient's pain score before surgery, and most of these patients report a 10 out of 10 pain score. So all this calcification really have affect the quality of life of the patient, increase pain, and even they affect the islet yield. So now I just told you in the last few slides the condition of the pancreas. It is like a really hard tissue, and it's extremely difficult to break it down. So here comes the story, that is about the development of collagenase that can digest this pancreas. Most of the collagenases that are available in the market have been extensively studied, extensively used for human use, and they are some of the best enzymes available. But how helpful are they for isolating islets from like rock hard pancreases in the auto islet transplantation? Only a few people, like probably my friend Dr. Bala, can tell you the story on this, because it's extremely hard to isolate islets using whatever collagenase that you use. But still, we still have a few steps that we can take to maximize the yield. So the enzyme to digest pancreas is a different field. It's a different topic. VitaSite has really contributed to this field immensely, because in my opinion, they are the only company which is there in this business from the beginning, like Bob was mentioning, from the development of Liberase HI way back in the early 2000s or even 1990s. Until now, they are always coming up with new products, new combinations. Our team has used this VitaSite enzyme also for isolations, but we also have used servocollagenase and the Roche also for the isolations. So the combination of enzyme is very important for the digestion of pancreas. In case if you want to know more about what is the right combination of enzyme to use and then what is the technical details, how to optimize the yield of islets from this hard pancreas is given in this list of manuscripts. I think Dr. Balamurugan is the author in majority of them, and Bob McCarthy also has really contributed immensely to this field as to how to find the right enzyme that can be used for isolating islets from these chronic pancreatitis pancreas. So just for those people who don't know much about the field, this is the general thing that we follow in our team. So we use a blend of collagenase and neutral protease. Actually, I want to point out that Bob McCarthy recently has published a commentary on this in his website. I encourage everybody to read that. That's very simple and very clearly explains the role of collagenase and the neutral protease in the isolating quality islets. So in our team, we determine the ratio of enzymes based on the following factors, whether we are isolating pancreas, the islets from a young patient or an adult patient. Is the pancreas already fibrotic? Based as soon as the pancreas comes out, our team members assess the pancreas condition and if it is fibrotic or not. And we also look for calcification in the image findings before the surgery. And we also look whether the patient has already undergone some surgery so that the pancreas has gone extensive damage. These are the things that we factor in to determine how much collagenase we use, how much neutral protease is used to get free islets. And then when we try to infuse the enzyme into the pancreas, it's a challenge because in majority of the time, the main pancreatic duct is already blocked because of calcification or some fibrosis or something. And that's very hard. Our team has already shown before that if the main pancreatic duct is blocked for a long time, all the acinar cells are completely destroyed. We call this as a complete acinar atrophy. In those cases, when we isolate the islets, we actually Bala calls it as natural purification. We get in the end only 100% pure islets. That also is being observed in a few cases. And the time of digestion for the pancreas, it all depends on how hard the tissue is and how small we can cut the pancreas for the digestion process. In the case of allogenic, where the normal pancreas is there, a normal pancreas is cut into 9 pieces or something like that. Whereas in the case of autologous, the size of these tissue pieces are very, very small to help the release of islets from the pancreas. Of course, we use the Riccardi chamber to isolate the islets from the pancreas or digest the pancreas. And as you can see here, we just cut the pancreas into, actually, I'm sorry, the slide is showing larger pieces. In the case of autologous, the pieces are very small, and we use the Riccardi chamber to add the collagenase enzyme, and then we increase the temperature to do the digestion. And of course, we collect the digest into large volume where the digestion is complete, and then we centrifuge it, and when we get the tissue volume. So the tissue volume now is important because at this stage, we again look at the Minnesota formula. If the tissue digests, the volume is about 1/4 of the weight of the patient, we decide to just bag the islets, wash them, and then prepare them in transplant media and take it back. This happens in majority of the cases. But as I was mentioning, in some cases, the pancreas does give high volume of the pancreatic digest. In these cases, we resort to purification. The goal is to give the transplant surgeon a minimum volume or a reasonable volume of islets so that when they infuse through the intraportal route, there is no increase in pressure that later can lead to complications like the thrombosis in the after the infusion. To avoid that, we try to minimize the volume. And as you can see in this slide, the islets are suspended in a bag and then attached to the patient, and then the surgeon infuses the islets through normal gravity into the portal vein. And during this time, again, as I was mentioning, the packed islet volume is very important to determine in the pressures. And then the pressures, if they're increased, then the surgeon has the option. Okay, if the pressure goes more than 27 or even 30, they is very concerned that that may lead to complications to the liver. So what do? We are left with the tissue. So then in some cases, starting from Minnesota, they place these islets into the peritoneal cavity. And then in some centers, they have reported that they can even place these islets into the omental space. At Baylor, we have also shown that there is a preperitoneal space along the lining of the stomach where these islets can be placed, and then they can really function for a long time. But there is no hard evidence that how long the islets can last in these extra hepatic sites. For example, the peritoneal cavity or peritoneal space imaging has been done for a long time to show that these islets are still active, alive or not. Nobody has done that thing. So but anyway, the surgeon has no choice. Instead of throwing the islets away, they try to transplant into the extrahepatic sites. So that is the technical aspects. Now I'll quickly jump into the Baylor results. So as I was mentioning, I've been working in Baylor for more than 22 years. And then during this time, we have performed 254 TPIAT cases, and we have also done 29 allogenic cases. And we haven't done an allo transplant in the last 6-7 years due to the regulatory hurdles. And this slide shows the demographic and baseline patient characteristics. More females have been selected for this transplant procedure when compared to male. And then the average age of a patient is around 39.5 years. And the duration of the disease or pancreatitis is like 7.1 years. And then some of these patients, like 8% of them, were already using insulin. So in the selection criteria, I mentioned that there must be an evidence of pancreatic islet function as seen by oral glucose tolerance test. The detection of C-peptide is very important for the selection of these patients. So even though these patients have used some insulin, like 8%, but their C-peptide production is good enough for them to be selected for the auto-islet transplantation. So the pain score is around 6, and then like about 15.5% of the patients have already undergone surgeries like Whipple procedure, Pisto, and distal pancreatectomy. And this is the slide that shows the islet yield. And this is the challenge that why we are talking about today. That is that the islet yield could go from like 50,000 islets or 25,000 islets or or 10,000. That's the lowest we have ever seen. And then it can go all the way up to 1,000,000 islets too. You may say how this variation comes as those people who are involved in islet counting, they know that if you have large number of large size or huge size islets, then they count a lot more. So in like a selected cases, like 5 or 6 cases, we have even seen up to 1,000,000 islets. And then whereas in majority of the cases, it's a lot lower. So the average islet yield in our center is around 383 islet equivalent, which is a decent dose. And then this is the slide on the patient survival. We are following patient for survival after TPIAT. At our center, at 5 years, 83.54 patients are still alive and work. Whereas this data, when you compare to Minnesota, Minnesota has a long-term follow-up. And they have even shown recently up to 20 years follow-up also. But in the data that they published in 2019, they show that at 5 years, their patient survival is 86.3, ours is 83.4. We are like, trending the same way. And this is the data on the insulin independence after total pancreatectomy with islet transplantation. Again, the purpose of this procedure is not to keep the pancreas function up. It's more about pain control. So, but still, we need to follow the insulin independence rate. As you can see here, about 27% of the patient at 4 years are insulin free. If you look at the data again from Minnesota, which is it's a large center with very established data and things like that. So you can see that they have also around 21 or 22% of the patients are insulin free over the long term. And this is the important thing, that is the pain relief. If you see the pain relief in our center, we look at the pre-transplant pain or narcotic use, The pre-transplant pain was 6.1. It came down to like 2.9 in 5 years. It's significantly lower than what was before. Even the narcotic dependence is also very significantly reduced. The narcotic-free rate and pain-free rate are also increased during this period. So just to summarize the Baylor data, we have performed more than 250 cases, and then there is a dramatic difference in terms of islet yield. We still are struggling to see how we can get high quality islets, and then we look for what are the combinations that can help us to predict the higher islet yield. And the third part of my talk is going to be on that. That is, our team has been trying to see what can we do to see whether there are better patient selection or better assessment of the pancreas that can predict higher islet yield and also post transplant glycemic control. I'm going to discuss about 4 manuscripts. The first one is this study on patients with genetic etiology, and as is shown in this slide, about I think 24% of the patient in our center have already been identified with genetic predisposition for chronic pancreatitis. The genes that we detected in these patients are more like 33% of CFTR, 19.6% of PRSS1, SPINK mutation, and then SPINK plus CFTR, a combination of these genes. So there is a panel of mutations that the patients undergo for screening. And if these genes are already shown to be mutated in these patients, then the selection is a lot easy because the surgeons can determine, okay, the earlier we do, the better it is. And that is what we are showing in this slide. When our analysis of these cases in our center showed that the patients who undergo TPIAT are at the ages like 32.3 versus non-genetic is 41.3. That means the surgeons are more inclined to operate on these patients than non-genetic. And the duration of disease is still like around 10 years or more. That is also important because the longer the duration, studies have shown that we will have less islet yield. And as you can see in this slide on the left side, the number of islets, the islet yield in the genetic cases is lower significantly when compared to the non-genetic cases. We also compared the subgroups of these patients with different BMI of 15 to 20 or 20 to 25, different BMI. Overall, we do see this general trend that for some reason we are able to get less islets from these genetic cases when compared to the non-genetic. But if you look at the even if you look at the post-transplant glycemic function, which is like, for example, if the patient is insulin-free, we call it as full function. If the patient has partial function, that means they require some insulin, but they can still have a normal glycemic condition with the insulin use, that's the middle level. We call partial function. If there is no evidence of C-peptide, then we call this a graft failure. And if you look at the genetic versus non-genetic cases at 1 and 3 years, the genetic cases, the insulin dependence rate is like only 22 or 13% at 1 to 3 years, whereas the non-genetic cases is like 29-41. So the exact reasons for this is still not known, but this is what our data shows. So then the second thing is this role of calcification. In this study, we analyzed 200 patients, and then we looked at the image findings, like is the calcified pancreas seen in the CT imaging? And if that is so, if the patients have calcification, in this case, out of 200, about 43 cases had calcification. We look at the pattern of calcification. Is it a focal? That means just you see the calcification or calcium stones in one area of the pancreas, or is the calcification pattern is throughout the pancreas? That's called diffuse calcification. This slide shows the pattern that you can see here. These are the CT images. You can see this is the focal infusion where the red arrow shows there is one calcium stone in this pancreas, whereas on the middle slide, you can see there are like 5 arrows. That means the calcium stones are seen throughout the pancreas. And on the right side, we are showing you the calcium stones. And even in the bottom, there is a scale that shows that how many stones were taken out of this pancreas. And the bottom, this is a schematic that shows that the pancreas is divided into three parts, the tail, body, and the head. If the stones are seen in two or more parts, it's diffuse. If it is seen in only one part, that is focal. And when we compare these three groups, I don't want to spend too much time on the different groups, but all it is interesting to show that if there's diffused calcification or DC group, the digestion time was longer. The undigested tissue left after the procedure was very high. The tissue volume at the end of the digestion is very low, and the islet yield is significantly lower when compared to the focal or the normal group. And the islet yield also is very low. And when we look at the post-transplant function, very critically, if you look at the E, that is the percent insulin independence rate, it is 0. We did 21 cases in this group, and unfortunately, none of the patients attained insulin independence. This is a little bit shocking, but that's what it is. If the pancreas has a diffuse calcification pattern, then the post-glycemic data is going to be very poor. That is the message from that study. Now I'm going to the third one, that is the fibrosis of the pancreas. It is common that if the pancreas is hard, it's a common knowledge that, that they are not going to get that much islets. But how do we determine that? During the isolation, we score the pancreas into different hardness. If the pancreas has got a soft nature, there's a 0 scale. If it is very hard, it's 10. So the team which isolate the islets assigns the score, and we compare the scores to the digestion time, tissue volume, islet yield in terms of IEQ per kg or total IEQ. All of this correlated with the poor islet yield. If it is a highly fibrotic organ, you get poor yield. And then we wanted to see, is there a scientific way of determining whether this fibrosis is directly affecting the islet yield? So what we did is we resorted to a common staining that's done in the pathology lab to look for fibrosis, and that is called picoserous red staining. And you can see in the slides on top, there is a normal pancreas, HNE and the picoserous stain. And in the middle panel, you can see that the red area looks for picoserous red, and it is a lot more in chronic pancreatitis cases. And then we looked at the area based on ImageJ software, and you can see there is more PRS positive area in chronic pancreatitis when compared to normal. And this PRS area directly correlated to poor islet yield, increased fasting blood glucose, and decreased C-peptide. So that is on the fibrosis part. Now, in the interest of time, I quickly go to the last part, that is the paper that led Bob McCarthy to invite me to this talk. That is the correlation of pancreatic laminin alpha. Again, our team is more interested in finding biomarkers that can really help us to predict the islet yield, and also in terms of post-transplant control of the glycemia. So what are laminins? Laminins is a group of glycoproteins in the extracellular matrix, and they are the major constituents of the basement membrane. There are at least 15 type of laminins have been reported in the human. And the function of this laminin is more in cell differentiation, tissue repair. This is important because as the disease is progressing, like in chronic pancreatitis, the organ tries to do tissue repair. Maybe that's why this laminin expression is increased. And in our lab, we chose to study laminin alpha 5 to see whether that can correlate. And this graphical illustration shows that on the left side, you see the islets, and they are surrounded by acinar cells and vasculature. And the ECM is the bed on which these islets are sitting. So ECM matrix, as you can see here, is there. And now, in our study, we analyzed about 30, 40 patients, and then we included patients of different etiology: alcoholic, autoimmune, hereditary, idiopathic, sphincter of OD function, and then pancreatic divisum. And the islet yield among this group was reasonably comparable. It is not like, significant different. So our team first measured the alpha-5 laminin in the plasma of the patient, and we found out the patients undergoing TPIAT have significantly more alpha laminin in the plasma circulating when compared to the normal cases. And then in our lab, we have Dr. Yang Lu, who stained all this pancreas with antibodies to laminin alpha 5 and panlaminin. And then he found out that the laminin alpha 5 area was way more than the normal pancreas. As shown in the right side, the green graph is the area for normal, but then when compared to the normal expression of laminin alpha 5, the alcoholic cases, autoimmune, all this etiology, hereditary, idiopathic, they had increased expression. So what if this increased expression, can it correlate to the islet yield? That's what we're trying to see. And in this particular slide, I'm showing that the laminin alpha is not actually on beta cells or alpha cells. He is stained here for insulin and glucagon. And when we do the merging of the slides, images, we can clearly see that the laminin alpha 5 is expressed not on alpha or beta cells, in other cells of the pancreas or islets. So in this slide, it is shown that this staining for laminin alpha 5 more closely attached to the CD31 positive cells or c-KIT positive cells of the pancreas. So that is where I think the tissue repair is taking place, and these these molecules play a role. And we also studied whether the laminin alpha 5 also associates with collagen 5 or perlecan. And we show clearly there is a correlation of laminin alpha 5 expression with panlaminin, collagen 4, and perlecan. That means the other extracellular matrix proteins are also associated with it. Importantly, we looked at the correlation and we found out that the increased alpha 5 expression actually leads to more fasting blood glucose after transplantation, less more hemoglobin A1C, less islet yield, and more use of insulin post-transplant. So just to summarize this part, TPIAT is an effective procedure. It can reduce pain, and it can really bring down the narcotic dependence, and it can help you retain the glycemic control. But the quality of islets is very important. And unfortunately, there is no easy way to isolate high quality islets from this pancreas, which have already undergone severe damage due to the disease. So some of the biomarkers that can help us to see whether to tell the surgeon that if the disease is really prolonged, the outcome is not going to be good. So whether they can do earlier, that's best. So with all the negative things, I'm going to leave you with this positive thing. You can just say, well, the islet is still poor. How are you going to improve the glycemic control? Our team in the last few years has embarked on a new method. That is, during this, on the left side, you see the method to isolate islets. But during the islet isolation, you do come across cells that are floating in the digest. So you try to focus on the pellet for infusion, but the supernatant has a lot of cell fractions. Actually, Dr. Jayachandra in our team has worked on this particular area, and then he has collected the cell fraction, and he's able to enrich the insulin or islet progenitor cells from these cells. And these progenitor cells, he is able to convert them into organoids. And he has developed a culture method which is specific or special to convert these organoids into insulin-producing cells. Now he has demonstrated that these organoids are similar to islets in terms of insulin expression and glucose-stimulated insulin release. And our goal is to have these cells converted into organoids that can be used as a supplement autologous islet infusion. The biggest advantage you enjoy is you don't need a lot of starting material. Even if a few ml of cells is plenty to grow these organoids into a large volume, and that can really help in the maintenance of glycemic control. At this point, I would like to thank my team for their support and the institution, and also thank VitaSite for the opportunity to present. And thank you. I stop here and I'm ready for any questions.
Thank you very much, Nazir. This was a phenomenal webinar. I mean, it's really well done. So is any questions anyone have? I can start off with a question. I think it's absolutely fascinating what you're doing. And I'm glad I could recruit you to give this webinar, because I think what you're doing is the absolute right thing, is trying to find biomarkers to try to predict the course of disease, because that's what's going to actually, be frank with you, allow insurers in the US especially to decide when to intervene earlier in a case. And I was just wondering if you could comment on that, how this has been has this influenced how clinicians manage these patients, and also has it influenced how insurers will reimburse this procedure?
So again, my area of expertise is more on the isolation part, not
Sure.
but still I can comment on it. See, luckily so far, all the cases where we are able to document that we can get viable islets and then transplant into the patients, and then that is evidenced after day 5. They look at the oral glucose, they look at the C-peptide secretion. If they see a C-peptide, that means the islets are functioning.
Right.
Never had any issues with regard to the insurance reimbursement. But in terms of patient selection, if the surgeon, for example, sees a patient, they screen for genetic etiology. I think currently they are screening for 11 genes or something like that. If it is positive, they're happy to go and schedule the procedure. Whereas in case of alcoholic use, or if there is any drug use that leads to this the disease, the surgeon is trying to postpone it. They are seeing whether they can cut down the inflammation, can they reverse the progression and all. While because they think that once the pancreas is gone, it's difficult. So in that disease process, in that difficult situation, can we take a biopsy? Can we take a sample and see, look, this patient has high of soluble biomarkers or some surface markers that can really help them to say that this patient is going down to a serious condition where we may not even get good viable
Right. Right.
we can do. So there are several papers from Minnesota, and all of them have indicated one thing. The earlier we do this procedure,
Yes.
the better the outcome in terms of islet function.
Yeah, I totally agree. So the second follow-up question is, as you nicely showed, the more fibrotic the pancreas, it's harder to get the islets out. My question to you is it hard to get the islets out because you just don't have a lot of islets? Or is it because you just can't get to them? You know the answer to the question?
So, for example, these patients before transplant, they do have good C-peptide. For example, a
Do
base
they? Okay.
C-peptide of 2.0, and they do a stimulation, oral glucose. After stimulation, the C-peptide goes to 4 or 5 nanogram. That means 2 times or 3 times more. That means the islets are functioning. So I think there are good islets in this tissue that is fibrotic. But currently, the enzyme that we use or the method we use to extract islets from stone like pancreas is not sufficient. So most of the work that your team or anybody has done is on allogenic islets where the pancreas are
Right.
normal. But this is like extremely hard, and Bala has come up with several techniques to maximize. For example, making sure the pancreas is cut into smaller pieces, go for a longer digestion time, and then using different concentration of collagenase and neutral protease. I do call him once in a while to get some advice, but this is not really well developed and practiced all around these centers. That's why I think the workshop that you propose will help us to come to a consensus as to you have a fibrotic pancreas, how do we maximize the yield? What are all the steps that we can take to do that? And I can see Greg Zott here, Tetsuya Kin here. These are patients, people with tens of years of experience. They can bring in their expertise to suggest us, maybe you should do this for fibrotic. Maybe this is what you do for calcific pancreatitis. So this particular topic needs more exploration.
No, I totally agree. And I think that's as I mentioned in that commentary, I think, the proteases have to be addressed. But what I found absolutely fascinating is I know there was a report at the last, I think it was the last IPETA meeting or the joint meeting, where there was a report from Paul Johnson's group at Oxford, which basically showed you reduce the neutral protease and it doesn't affect the yields. And I know there are other groups who are doing the same thing. They're not using as much neutral protease. So then the question becomes, okay, is it the collagenase? and I've always thought, well, it would be interesting is how can you heat up, have a little hotter, so to speak, digest without damaging the cells, and maybe that will free up some of the collagenase. I just don't know. I mean, so it begs the question, it really begs the question that there has to be more work on fibrotic tissue, which is, of course, just not chronic pancreatitis patients, it's livers and other things.
Hi, thank you. Bashoo, nice talk. I really enjoyed it. Did a good job. I just had a quick question about the laminin part of your talk. Do you know if there's something that will help improve the breakdown and removal of laminin? Does the neutral protease do that, or would, thermolysin? Is there other enzymes that could go in and do the breaking up of that protein and then releasing islets in a little better fashion?
That's a good question. Actually, it's for a biochemist to see whether the thermolysin or neutral protease is more effective in removing the laminin thing. But my study, unfortunately, was conducted retrospectively. So what we did is we looked at the pancreas after the fact that we already isolated the islets. The thing is, we used the same enzyme combination to induce isolation. So that's why we are able to come to some conclusion. But this is the study that is, maybe we can do where we can collect the supernatant during digestion and measure the laminin that's being released and then quantify based on the gram of pancreas used and then how much laminin is coming out and see whether this particular neutral protease like thermolysin or or any other combination is more effective in removing the laminin. So that has to be done, but our study is unfortunately retrospective.
So
Yeah.
I think that
Yeah, I was gonna say, would Bob have a comment on that too? And cluster pain or something, is there something that would work on the
yes.
laminin?
And that's where I was going to chip in. That's what the whole commentary was written about. So I think the beauty of what Nazir has done is to take just clinical materials and really give an insight into how the laminin alpha 5 can affect islet yields. I think the other issue, which somebody could do, and we're more than willing to supply other enzymes, I think you have to use complementary specificities. And we've made a porcine pancreatic elastase for this reason. Elastase is a very interesting enzyme. And so please, if anyone wants to play around with this, I think what you could do is take that undigested tissue and then see whether or not it breaks it down. I don't know how you set up the study, but I mean, if anyone wants to think about designing a study and doing that, we'd be more than happy to provide the enzymes for people to do that type of work, because I think that, to me, that is the answer. You're going to have to use complementary proteases.
I'll just comment on Greg's point. By the way, it's a very nice talk by Nazir. Thanks, Bob, for making this arrangement. Greg, as Bob said, maybe we have to supplement more elastase enzyme to digest these fibers. As you know, there is so much of extracellular matrix apart from regular collagenase. There are many different compounds are expressed, especially elastase is a main one. In my view, I think supplementing additional compounds like elastase will be very helpful to digest these type of pancreas. I think ultimately, Bob should come up with a new enzyme formulation for digesting these chronic pancreatitis pancreas. The regular enzymes which we use for our allos, may be really not sufficient.
So I have a quick question. Has elastase been used in normal allogeneic pancreas?
Not really.
Okay.
Elastase.
I wonder if it had an effect on islet function later on. And if we could find that, on a normal pancreas, that it doesn't affect islet function, then maybe it would be good to go in and use with auto.
You would think that it's, elastase, and why we get it out of porcine pancreas. It's there as a regular pancreatic zymogen that gets activated. I will tell you an anecdotal case. We, as you know, we did early days of Vitasite, we did a lot of pig islet isolations. And in one islet isolation, we got these tremendous islet yields. And Drew Brady was doing the work on it and decided to take those supernatances to look for other enzymes. The other enzyme was elastase by a specific peptide substrate. Of course, when you put elastase in for the next animal, it didn't work, which is usually the rule. But my guess would be is you could always, if you wanted to, again, Bala gives me too much credit. What I want to do is would be more than happy to share our knowledge to work with others who want to look at this, because I think it's the community of researchers that has to kind of point the direction to what will work for new formulations. And let's face it, the stuff that Bala did actually in 2012, when he had a very nice paper for the new enzyme mixtures, showed the problems you can get into with thermolysin, and showed also that you had to use kind of more gentler protease. And, you know, of course, subsequent studies, we showed that our BP protease is equivalent to getting good islet yields versus the NB protease from
Recording in progress.
so any other.
So the first one sounds like a stupid question. I'm
So
in Dr. Rita Bettino's eyelid program, and we do clinicals. And one of the things I was wondering is that does necrotic tissue ever play a role in the challenge of eyelid quality following a transplant? Because there were a couple of cases where we had to flush out and even cut off the necrotic tissue.
Good question.
I think so. Actually, in our center, we have done also a couple of cases of necrotizing pancreatitis. That is the worst case you can see, because most of the tissue is already scarred, and then there is really a lot of necrotic tissue, and it's hard to isolate viable or high quality islets. So but the number of cases are very, very small. But these patients have come up with a lot of high pain score, who are already diabetic, and this kind of cases. So I'm not surprised that you saw a lot of necrotic tissue, and I'm sure the islet yield was not really optimal.
Okay. My other question is, how are you looking into like eyelid function? Like, are you doing the form of a GSIS, or are you doing something different?
No, in the case of autologous transplants, in the interest of time, and also since we are transplanting everything, there is no GSIS performed on islets. Our first indication of islet function is after a week, you see, they do the patient C-peptide 5 days or a month later. And then if the C-peptide, see, some of the patients are on tube feed for 1 week, so that C-peptide is not really high. Whereas a month or 3 months later, when you see a good C-peptide in this patient, that shows the islet function is there and it's robust. So we do not perform in vitro assay for insulin release.
Okay. So then in that case, like, are you like taking like blood samples or something, or like just to be able to measure the C-peptide levels?
During the infusion, we do have a study where we draw the samples, but unfortunately, this C-peptide is more of islet death or something, destruction or damage. It is not necessarily a metabolic stimulation, so that C-peptide that you get during the infusion is not very helpful. So you need to have the islets rest in the patient for a few days, a week or two, then they see the C-peptide. That's more indicative of the islet function. So what we do during the infusion time, the data is not really reliable on islet function.
Okay.
If the islets are necrotic or they die of mechanical damage, that releases C-peptide in the circulation. So it is not very helpful.
Okay. Like, we also do like other isolations, and there was like an instance where I looked at like insulin secretion through like an ELISA, and then I was like double checking with the peptide kit, like the C-peptide, because I know those two are kind of related in a way to measure the function.
Yeah, in the case of autologous transplant, we don't want to take the islets for testing and all because every islet that goes into the patient is more helpful. So
Okay.
that is the purpose. So whereas again, these assays are not necessarily very helpful in predicting islet function. So currently, in our in vitro assay.
Thank you.
I think the answer to Kristen question, in some selected cases in the University of Minnesota, we checked their insulin secretory capacity and compared with the brain dead donor islet cells. Evidently, their insulin secretory capacity from these autologous preparations, they are high. Because it comes from a living donor, less cold ischemia. So I don't know whether even if they have a less or poor insulin secretory capacity, no matter what, we have to transplant. That's why,
Right.
not many times, we do this assessment. Then, the answer to your, the previous question, the necrotizing pancreatitis cases, again, it's really challenging. It's kind of pancreas is like a oozing out. But, even again, our goal is to collect whatever the maximum number of cells we can collect from those type of pancreas and infuse it, even if there is a compromise in the quality of islets.
Okay, is there any other question?
Yeah, thanks. A great presentation, a great discussion. I wanted to go back to one of the questions that Bob asked, which related to getting these patients in earlier to see the surgeon and what are the rate limiting steps. And at least in my experience, the third-party payers were not as concerned about this as an early patient. Why are you doing it this early? The rate limiting step was the gastroenterologists who don't want to give up these patients to the surgeon. So they hate to, hopefully there are no GI docs here, but they make quite a living off of putting stents into these patients. And I think there might be some general agreement that the earlier a patient has a TPIAT, the better the outcome is going to be. One thing that I wanted to bring up in this whole laminin discussion, the laminin 332 external matrix molecule, and I've studied it for other areas. It wraps around the islet, but it is also almost endemic to the entire islet core itself because it wraps around all of the blood vessels. So as we start thinking about using an enzyme that will break up the laminin 5, the laminin 332, the new nomenclature molecule, that could further dissociate the entire cellular milieu within the islet. And we have to be careful of that. Laminin 332, there's a lot of work going on in its relationship to cancer and basically laminin's effect on cell cycling and other things. It's not just a barrier function. There are other things there. So it has to be a little bit. One last question, which just for Bashoo. Have you looked at other correlations with outcome and specifically size of islets? I'm a microvascular person, so it's much easier for me to revascularize a small islet than a large islet. And I'm always wondering from all these different groups, have you ever correlated a small a isolate that had a much more small islets than large islets with outcomes?
Yeah, thank you, Dr. Stu, for this wonderful comments. Actually, I totally agree with you that when it comes to the patient selection, when we say earlier is the better, but the surgeons or the gastroenterologists are not inclined to select these patients in the early stage. They want to wait till there is no other option. This is the last option they want to go. And by the time the last option comes, it's maybe too late for the pancreas. And regarding your comment on, whether the laminin can be, can be separated from the islets, of course, I leave it to the enzyme specialists like Dr. McCarthy or Bala to come up with something where we can do that. But the question that you specifically asked, can you repeat that for me? The third question for me?
Yeah, it's the relative size of
Yeah. Okay. Yes. That one,
Colorado
yes.
being
Our
better.
our team has published on that, and even Bala and other centers also are in agreement. Smaller size islet seems to do better in terms of survival after transplantation, insulin secretion. We have even separated large islets, middle islets, and small size islets. We show that the smaller islets work better in terms of insulin secretion. And even in the clinical settings, there are publications out there where they correlated smaller size islets really contribute to better function after transplantation.
And do you know why? Any speculation?
Maybe
why?
the necrosis after infusion, the islets go into a hypoxic condition, into the liver, microvasculature. The larger islets may crumble, they may die because of necrosis, whereas the smaller islets survive better and then their insulin secretion is retained. So maybe that is the outcome.
Yeah, and we're finding that same thing with spheroids and organoids. The smaller the structure of these spheroid organoids when they're transplanted, the better outcome, because you don't end up with necrotic cores, which you often do when you're using large organoids or spheroids. Thank you.
So maybe I can comment on Stu's question. Dr. Stu, regarding the islet cell size, okay. So how many bigger islets we get from every preparation? Even if you check our counting sheet, we may see 4 or 5 large islets in our counting sheet. So I think the concept of small islets and large islets are really applicable only to rodent islets. In those ones, you can clearly see smaller islets versus larger islets. But when it comes to human islets, this is my opinion. When we say small islets, maybe they are all fragmented islets. Maybe they are not small. So when I see larger islets, in general, I feel that it's an intact islets. It's not a broken islets. So I'm happy that I'm getting more larger islets. I'm not really worried about the later vascularization aspect. The islet is intact. I think, because many times, that means like if we break the islet cells, maybe they will really engraft well. We don't know those things, Dr. Stu. And then another one, Dr. Stu, as you said, I think the main one is we have to have a nice imaging system to assess the pancreatic cell mass. Then it's easier to convince the gastroenterologist. You see, it's already the pancreas has only 20% parenchymal mass. If you leave it, maybe we may have 0% parenchymal cell mass within 1 year or 2 years. I think because by current imaging, we don't see that the cell mass, parenchymal cell mass in pancreas. What we see is, we may see like an atrophic type of pancreas or calcification in the pancreas or dilated duct. I think the best is if we have a right imaging tool, we can tell, okay, the pancreas is already in a very bad condition. You see only 30% parenchymal cell mass. If we don't do the pancreatectomy now, we will end up nothing from these type of pancreas. This is kind of my suggestion.
I would like to add on this aspect that currently our team is taking sections of chronic pancreatitis tissue, comparing to your normal pancreatic tissue using spatial genomics. Actually, my colleague, Dr. Michael Lawrence, has already done some preliminary studies. It's amazing. We are coming up with this amazing data as to what type of cells are there in the chronic pancreas. That will be the focus of future studies. A lot of exciting things to come.
No, that's very fascinating. Yeah, very interesting. And like I said, I think to get the clinicians to buy into it has to become common knowledge about the path of the disease.
Hey, Nazir, great presentation. It's awesome to see great work coming out of the lab. My question was about the data around laminin, because that could potentially be one of the, gremlins around always receive or sometimes getting embedded islets, the so-called embedded islets after autologous pancreas digestion. I'm wondering if, to Stu's point, we perhaps need to be careful about, adding elastase to every prep. I'm wondering if laminin could be used as the soluble marker, perhaps pre-pancreatectomy, to see if the case could potentially benefit from the addition of elastase rather than just adding it to every procedure. What do you think?
Yeah, thank you, Charles, for your nice question. And I haven't not mentioned, but it's very common for us to see a lot of embedded islets. That means islets are surrounded by acinar cells. Even the best combination of collagenase and neutral protease, or we use in our lab, is unable to get those free islets. This has always been a challenge. So the laminin part in this embedded versus free islets is still to be explored. And then, we also show that in the circulation of chronic pancreatitis patient, the level of laminin alpha 5 is significantly more than normal. That is already, that can be measured before transplant. Whether that will help us to formulate the right enzyme combination, we haven't done that yet. But I think those studies have to be carefully planned and then analyzed to see how we can really tackle this problem. Thank you for the question.
Okay, I hate to be the pain here, but there was a time that we got a pancreas with it was from a donor with cystic fibrosis. It wasn't for clinical or anything, and I remember like we were having trouble distinguishing fat from pancreatic tissue, and my question is like, what made you want to look into a pancreas with a CFTR mutation that's often associated with cystic fibrosis?
As I was mentioning, in our genetic etiology cases, we have seen a few CFTR mutations. And yes, it is not uncommon to see the pancreas being such a bad shape. There's difficult to distinguish between pancreatic tissue and the fat surrounding it. But as I was mentioning, we try to digest the pancreas as much as we can, and then collect as much digest as we can. And again, without purification, also we infuse. So the distinction between fat and the pancreatic tissue is hard in a chronic pancreatitis case.
Okay.
Yeah, maybe I can add my comment to Kristen. Kristen, as you said, I have handled 3 cases. They are all pancreatic lipomatosis. The entire pancreas is fat. There is no exocrine cell, and the islets are in between. So you cannot really distinguish, which is pancreas, which is fat. So, in a way, the digestion is very easy if you do interstitial injection throughout the pancreas. You don't need to separate out fat or pancreatic tissue. The entire mass, you inject the enzyme, and easily you can digest those pancreas. There won't be any exocrine cell, mostly just like a pure islet population from those ones. So the CFTR caused pancreatic lipomatosis cases, yes, those are all very rare cases. We one for
I'm sorry if I'm interrupting, but I thought like when the fat is like developing in like the exocrine region, it's like doing something to like the islet function.
I'm not understanding your question. So that when the exocrine cells are replaced with the fat, what is?
I thought that's like lessening like the islet function, like regarding insulin production when it's needed.
Well, I can comment on that. In our lab, we have a few cases of called complete acinar atrophy, where when we see the pancreas, we have also taken sections and see nothing but fat in this thing. But these islets, when they're isolated and transplanted, they function well. We have shown that even in patients who receive this 100% pure islets, after a week or 2, after a month, the C-peptide function is fine. So this is the amazing thing about chronic pancreatitis. Even during the destruction of acinar cells, there's a fatty infiltration, the islets remain intact. They do make insulin, they do make C-peptide during the pre-transplant screening or even after post-infusion. So islets, for some reason, are protected by this disease condition.
Yeah, and let me just add to that, Stu again. After studying fat for the past 50 years, fat is actually quite good And in this particular aspect, if you look at the adipose tissue in those fatty pancreases, a majority of the cells per cc are endothelial cells, are the microcirculation. So every time you see fat, you're bringing a new microvascular bed in closer association with whatever tissue. So the beta cells that are, and the islets that are surrounded by all that fat, they're now highly vascularized, which is good to bring nutrients, but also great to get the insulin back out of the islets. So think of fat as a good thing.
Sure.
It's just all this stuff that I've like looked into regarding like lipid transport and cholesterol and all that other stuff. But I find that interesting.
Yeah, I wonder if Peter's still on the line. You had written a comment. Peter, you still there, or?
I am still here. I just threw up my hand too because I was wondering about that. I'll go to my comment in a second, but first I was just going to
Sure.
ask, from what was just discussed. Again, I don't have a lot of experience using the pancreata that are mottled and seem to be fully infiltrated. They're very marbled and fully infiltrated with fat for islet isolations. They're very soft, and again, when we're trying to dissect out the pancreas from the surrounding fat tissue from these, usually there's deceased donors that I'm considering here. So we're dissecting away. Usually they're very, very high BMI, in which we see these where we can't separate the pancreas from the fat tissue. But it's I'm hearing is that we should just do what we can and then just go ahead and digest, and we'll get amazing islets out of it. Maybe the yield will be low relative to the initial weight that we started with, because we're going to melt away, so to speak, all of that fat. That's all going to go away, but we're going to get very highly functional islets out of that. Is that what I'm hearing?
Yes, I think I agree with your comment on that. That is, in our experience, when we have like this complete acinar atrophy cases, we have published a paper on that in Cell Transplantation. So this pure islet that come out of this fatty pancreases, they work well. We have done even microRNA assessment of that particular tissue. So the data looks that, the pancreas coming out of this fatty pancreases are good. Actually, even in allogenic field, people have published that when compared to low BMI donors, a little bit of a high BMI donors, the islets are really, functional, and they're really high quality.
Yeah,
That's very exciting.
Yeah, let me
Sorry,
just add to that. The enzymes used for islet isolation, so pancreatic digestion, we've used on pure fat samples, and they work extremely well. Following that digestion of fat in a fatty pancreas, the adipocytes are incredibly buoyant. So during those first centrifugations, you're going to lose all the adipocytes, so you don't have to worry about them.
Oh, yeah.
And
Yep, that's my experience as well.
and the majority of cells that are left from that fat are endothelial cells that have been shown in a lot of other studies will reform a vasculature. And in some studies with islets, those endothelial cells have been shown to be able to penetrate into the islet and actually hook up a process known as inosculation with the blood vessels that are in the islet. So you might actually want to start throwing a little bit of fat back in with the whole pancreas samples and take advantage of the microcirculation that exists in fat.
I mean, I'm fascinated by this. It's telling me that I should not be dissecting my pancreas I shouldn't be trying to get so close to the parenchyma. I should leave quite a bit of fat maybe on the surface and just proceed ahead in order to try to maintain those, especially like if what you're suggesting is true for the clinical aspect, that when we implant these into the liver, that the endothelial cells that would go along with it would try to implant it, if for autologous at least, where we don't have to worry about rejection being a serious issue, that maybe these would find a way to embed themselves into the liver in order to help bring better circulation to the islets and improve embedding.
Yeah, absolutely. One thing to consider for allogeneic islet transplantation, you can use autologous fat, isolate the microcirculation from that autologous fat, and then co-transplant the allogenic islet with autologous microvasculature. In some other forms of transplantation, we and others have been able to show a reduction in the need for immunosuppressants. because the
That's
blood and the
awesome.
cells, the first cell they're going to come in contact with is an autologous microvessel, autologous endothelial cells. And Bala, you know, for years we would get together and you'd be cutting the fat away, and I'd say, "Why in the world are you cutting away the good stuff? Leave the fat in."
Yeah, that's true. I think adding vasculature, primarily we can get a lot of peripancreatic microvascular fragments, stromal vascular fraction cells from those fat. Those cells will really help islet cells. The only thing is we have to save them during isolation because otherwise they will be washed away.
Right. That's the one thing that I guess would be the concern, is that during the centrifugation, you're going to, well, I guess how much of the endothelial cells you'd lose.
Yeah.
And then during purification, I wasn't sure where they're going to settle out. Are they going? So when we do our purifications in our cobe, we first we collect our islets tissue, our digest, into hypertonic solution in order to generate a greater discrepancy between the acinar tissue and the islet tissue and the actual insulin producing islets, because the acinar tissue will lose more of its fluid, will become more dense, so that when we then do density centrifugation, we have a greater separation between them. It's much easier to purify our islets that way. I assume that's standard practice for everybody's islet programs. But I would wonder where these endothelial cells are going to end up in that separation.
No, that's already too late, Peter. Nothing,
Yeah.
after, during purification steps and all, there will be a very minimal quantity of your endothelial cell population. That's why our final product is having a very minimal endothelial cell population, because those are all small cells and they're all floating cells, and then they are washed away during the process.
Yeah, they're washed.
So we need to save some of the supernatants during the digestion. We need to save some of that supernatant. We need to, and then
exactly
sort of rewash that and transplant that in addition. Okay, so it's a secondary step.
Yeah, Peter, they're lost in the first wash. Is
Yeah, that's what I'm hearing. First wash, because they're floating up with the adipose tissue.
Yep.
This is kind of a hypothetical. I'm sorry if I interrupted, but let's say like all the fat is coming from a pancreas, which happen to have pancreatitis, but maybe like an undiagnosed diabetic or a pre-diabetic. Like, is the fat on there still a good thing?
As I told you, some of the patients who are selected already have impaired glycemia. That is like, they have already are insulin use. Whether these pre-diabetic or type 1, type 2 diabetic, type 2 diabetic patients, whether their pancreas is having a different quality of islets, we have not done a detailed analysis. But again, like the discussion is going on, if you have a fatty pancreas, you tend to get good islets, and these islets do reasonably well during the post-transplant time.
Okay, that was just a curious question.
Yeah, maybe I can
Kristen, one other part of that thing, we all know that if patients continue to inject their insulin at the same site, fat is going to develop at that site. Insulin is known to stimulate formation and proliferation of adipocyte progenitor cells, which are the endothelium, into more adipocytes. So I think part of your question, which is critically important, is there anything negative about the fat there? Fat will develop in areas of inflammation. So you get an inflammatory adiposity, steatosis in certain areas. So fat can be a sign of a good thing, but it also can be a sign of a bad thing, inflammation. And in that case, there's some sort of inflammatory response that is taking place that you do all these isolations. You've got probably more inflammatory cells associated with your islets.
Maybe I can just comment on this question. For example, why we need to select high BMI donors for our islet cell allotransplant. Fortunately, we get only high islet yield from those pancreases, even if the islet cells functionality may be compromised, but no other option for us. If you take a pancreas from a lean donor, it's highly challenging to get this 5,000 islet cells per kilogram body weight to release the product.
So I want to go back to Peter to get to your question you asked on the chat.
Oh,
Please.
yes. I was wondering, I don't know if, I know we have Dr. Balak here and Dr. Bashoo. So maybe someone has done this. I have not checked in the literature. I work in a number of different programs at UW. One is our Islet program, but I also work in another field where we're working with liver transplant and kidney transplant. And what we've started doing is we are currently in preclinical studies, so animal models, where we are using lipid nanoparticles that are labeled with DIR, which is it's a lipid labeling system that it fluoresces at IR. It effectively, yeah, it's fluorescent at infrared wavelengths, and we are using this to assess the performance of genes that we're upregulating into kidneys and livers. We're perfusing this into kidneys and livers and then transplanting them and using this to watch what's happening. And it occurs to me that this is something that could possibly be used with the islets after purification, most likely, but a way to try to monitor the islet load itself to see how long the islets are remaining implanted versus dying off, being digested, being removed by the immune system or whatever else is happening. It was just something I wondered about. Has anyone investigated this, ways of imaging our islet load to see when it's failing, to be able to assess when it's failing, other than simply watching the C-peptide levels drop in the patient?
Actually, thank you for your comment. This is a very interesting thing. So the Swedish team with Dr. Ole Kosgren, they have published papers where they've done some PET imaging after islet transplant. They found out where the islets are once after the intraportal infusion, which part of the liver the islets lodge in and how long they work. There is an interesting study on that. You're welcome to refer to the manuscript, or I'll be happy to share it with you if you want. And also, City of Hope has done a great amount of work as the type of probes that can be used to track islets after infusion into the portal vein. That also studies there, but more clinical side is the Swedish group that has published on it. So I hope your work also brings out a novel way of estimating islet function after transplant.
Yeah, I think I'll look up these manuscripts and what City of Hope has and what the Swedish team has to see what their protocol is and to see how well it can be adapted to what we're doing in livers and kidneys to see whether or not there's a way to improve upon it or utilize it, or if I'm just barking up the wrong tree. But thank you very much.
Is there any other questions before we break? Well, I want to thank Nazir. Thank you again for such an informative webinar on a very special topic that's really is any improvements that are made, as we all know, will result in higher quality of life for these patients. So I think it's phenomenal that you and the others in the community are trying to improve these processes or find biomarkers or whatever. The second thing, just to get to my first comment, I think I've now got a clearer image of if we have a online series, there's a lot of questions. It's almost have a general discussion about a number of topics. So yeah, I again appreciate all, and thank you again for participating, and we will announce the next webinar when I can recruit a speaker. Last thing, if anyone wants to be a webinar speaker, I usually do the recruiting, but if somebody wants to volunteer, please just contact me directly. Thank you, Bob. Thank you. I want to thank everybody for a very, very, very fantastic discussion on this topic. Yes. And again, thanks VitaSite for inviting me to give this webinar. Oh, you're very welcome. All right.
Thank you all.
I'm going to sign off. Thank you.
Thank you.
Thank you.